Good afternoon, everybody. We'll start with the first session, lecture in this session. I'll request Dr. K Mohandas to come for his presentation. He is in the Department of Gastroenterology, Hepatology and Nutrition for the Adjuvant and New Adjuvant Therapy of GIST. Dr. Mohandas, please.
Chairpersons and friends, good afternoon. I've been asked to give evidence to support neoadjuvant therapy and adjuvant therapy in patients with gastrointestinal stromal tumors. And so what I'll do in the next 12 minutes is I'll present the gist of the gist. To begin with, GIST used to be an uncommon tumor, but now we diagnose it more and more often. Everybody is aware. We are able to reach various parts of the GI tract, and the pathologists are also familiar with GIST, and therefore there is a definite increase in the number of GIST being diagnosed. But the real message I would like to give is that in the 90s, when these new treatments were not available, the overall survival for all patients with GIST was about 30-35% at 5 years. So it was not very good. It is something similar to stomach cancer or colon cancer. And a lot of attempts were made to improve the outcomes by giving various chemotherapeutic drugs, but nothing really happened and there wasn't much progress. Then came the famous paper, the discovery of the KIT mutation in GIST patients and the remarkable response to imatinib, and the study that appeared in New England Journal of Medicine, which showed that if you give imatinib to patients with metastatic GIST, you will have very good response and very good survival as shown in these curves. So just to illustrate, but at the same time, it was obvious that all the patients did not have a very good response. Response means shrinking of the tumor was seen in about 50% of the patients. And yet, a lot of them survived for a very long period because there was a metabolic shutdown of the tumor, which is typically seen on a PET scan nowadays. And this is an example of a patient of ours. You see a large tumor with a typical central ulceration, like a volcano lesion. And after 3 months of imatinib, you can see the tumor has shrunk and the ulcer is almost healed. This is an extreme example of a patient. You can see there is a very large tumor in the duodenum and in the periduodenal region, which is bulging into the stomach, the top panel. And you can see on the PET scan that there is so much of disease all over the upper abdomen, particularly on the right side. And after 4 months of imatinib therapy, you see that you wouldn't believe it is the same duodenum. The duodenum has completely cleared. The bulge in the antrum of the stomach has gone away. And on PET scan, there is a little bit of activity. The tumor is completely shut down. So with this kind of response, there was a great hope that if you add similar agents in the perioperative setting, that you would improve long-term outcomes of patients of GIST. And it gave a hope that if you combine it either before surgery or after surgery, that is the adjuvant which is given after surgery, that you would have good outcomes. So the early trials, there are 3 adjuvant trials, and I will quickly go through them. The early trial that used was actually a phase 2 trial with about 100 patients. It had excellent 1-year survival, 3-year survival, and 5-year survival. 83% was the 5-year survival in these patients, and you can compare it with the previous data that I showed you. So from 35%, you have now 83% survival. And the drug is relatively non-toxic. It can be managed quite comfortably. Following this, we live in an era of evidence-based medicine and you need randomized trials. And so we had a placebo-controlled randomized trial with adjuvant imatinib that enrolled almost 800 plus patients. And what did this trial show? The same thing, that with the use of adjuvant imatinib, 400 milligrams daily, for 1 year, the disease-free survival as well as overall survival improved. But what I would like to show you is that these next 3 graphs tells you what actually happens to the risk factors. Like in colorectal cancer, we don't give adjuvant chemotherapy to everybody. We give it to only the high-risk group, those who are node negative or those who have a T2 tumor node negative. We wouldn't give any adjuvant therapy. So similarly, risk stratification, very nice data out of this trial. This is for patients with a tumor which was small, less than 5 centimeters in size. And you see the graph between those who received and those who didn't receive is not much of a separation. When we look at a larger tumor, between 5 and 10 centimeters in size, you see the separation being bigger. And this is for the patients who had tumors that were more than 10 centimeters. And you all know that GIST can assume very large size. The higher the risk, more was the support for the use of adjuvant imatinib. Subsequent to this, if one, you remember those graphs, you see that after a few years, the survival is dropping, which only means that patients are getting recurrence. And there was, based on preclinical studies as well as observational studies, that if you were to continue the imatinib for a longer time, that you would get better results. Therefore, the Scandinavian group did a trial combining, giving imatinib for 1 year, which had become the standard, versus giving it for 3 years. And that was a study published last year in JAMA. And what it is show is that when you give it for 3 months, you see the curve on top, and compare it with 12 months, you see the difference. So giving imatinib for 3 months was now evolving to be the standard of care. And if you see at the overall survival, the difference is not so much, simply because people who progress were put back on imatinib, so there was some amount of crossover, and therefore, though you don't see much of a difference in the overall survival. Subsequent to this, there is yet another large trial which is ongoing. Only preliminary data has been presented at the ASCO this year, which shows that, which is slightly different than the data that I showed you in the previously 2 published articles. And this study showed that the results are not as good as what has been proposed in the Scandinavian trial or the Lancet trial. So the take-home message from all these 3 sets of randomized trials is that adjuvant imatinib, 400 milligrams daily for 3 years, significantly reduces the recurrence rates, improves overall survival in patients with high-risk GIST. Now, what about when this drug is working so well in advanced disease? It's obvious that you get tempted to treat patients with large disease, shrink it, and then operate on them. So there were attempts and anecdotal reports of using imatinib in patients with large non-resectable tumors, and that is how the drug was moved into the neoadjuvant setting. Unlike the adjuvant setting, the evidence for use of imatinib in neoadjuvant is not so good. There are a couple of phase 2 trials, small trials, not very well controlled, but nonetheless, they show that it helps. So this is the looking at a selective group of patients who have participated in the BFR14 trial. So it's a very small set of about 25 patients. And what this is what is called the waterfall plot. You see in the left side, the tumors have progressed. So you see 6 patients in whom the tumor has progressed, and the vast majority of patients, the tumor has reduced. And you can see the reduction is very high in some of these patients, of the order of 40% or more. In other words, just like those pictures that I showed you of our own cases in the beginning, that many patients, the tumor shrinks considerably and they become amenable to surgery. And naturally the survival, both progression-free as well as the overall survival, is quite different in patients in whom the tumor shrinks and they are able to undergo resection. There has been one phase 2 randomized trial that looked at using imatinib to improve outcomes in patients with large, non-resectable or difficult to resect cysts. And this trial showed that the 5-year progression-free survival is 57% in the group A, that is group A comprised of people with big tumors. Group B is those with small tumors, so again, bigger the tumor, better the response. So the take-home message too is that there is increasing evidence that neoadjuvant therapy with imatinib improves resectability and survival of patients with large GIST. There is no increased toxicity in post-operative complications in these patients. However, the level of evidence would be 3 because these are not large randomized trials. What about Indian data? Our group, when I was working at TMH Mumbai, we had published 2 papers, one looking at the neoadjuvant results of some of our patients, which was published in the World Journal of Surgery last year. What we found is that by using neoadjuvant therapy for a mean of about 8 months, 8.5 months, we were able to improve the resectability, achieve more R0 resections, and improve outcomes of these patients. What about adjuvant therapy? This is a study we published this year in Indian Journal of Gastroenterology, again showing that if you use adjuvant therapy, you definitely improve long-term outcomes of these patients with just following a complete resection. Essentially, imatinib is a relatively safe medication but can occasionally cause complications, so one needs to understand that that it can have serious complications sometimes, but otherwise it can be handled by most people. It's important in oncology that we stratify the risk. Patients with highest risk get the most intensive treatments, which increases the cost of treatment as well as it increases the side effects. So for GIST, there are various scores. Some are available on net. You can actually feed in the data and you can get the risk scores. The simple thing is to have a mitotic index, so ask your pathologist to give you the mitotic index. If it is more than 5, it is a high risk. Then the tumor size, which can be measured very accurately with the CT scan. So if the tumor is bigger, more than 3 centimeters, the risk increases. More than 10 centimeters, the risk is very high. And the risk also varies a little bit between stomach, duodenum, jejunum, and rectum, and therefore, based on this, you can have a risk stratification program, and patients with very low risk may be observed. All others, it would be advisable to give adjuvant imatinib if they've undergone a resection, and if they're very big, then one could think of using pre-operative imatinib to shrink the size and then operate on these patients. There is a general thinking among the medical education is that giving a lecture is the best way to remain up to date and remember the knowledge. You get about 80% retention. Listening to a lecture, you only retain the information in 5% of occasions. In other words, 2 days from now, most of you would have forgotten what I spoke to you. So I'm going to give you a homework. This is a patient of ours who had a rectal cancer simultaneously with the sickle cancer, and when we did the CT scan, there was also a 5 centimeter GIST. How will you manage this patient? Thank you.